Hi, I'm Paul Epstein, and I'm going to talk to you now about the pharmacotherapy of schizophrenia and psychosis. Um, the next slide shows what objectives of this talk will be and what things you should come away with getting an understanding of, particularly what receptor systems the antipsychotics interact with, what effects result from the interaction, both the wanted and unwanted effects, and in what way clozapine and the other newer antipsychotics are considered atypical and what the implications of this are. Um, so, as far as what types of antipsychotics there are, the first ones became available in 1950, as shown on the next slide. The chlorpromazine was the first one synthesized. Is developed serendipitously as an antihistamine, but found to have a beneficial effects for treating schizophrenia. The trade name of this is Thorazine, and it sort of revolutionized things because prior to 1950, patients with schizophrenia were more or less confined to hospitals for most, or centers like that for most of their entire life. Where when the phenothiazines, which is what the type of class of drugs the chlorpromazine is representative of, became available, it enabled many of these patients to leave the hospital and lead somewhat somewhat normal existences. So the phenothiazines are a three-ring structure as shown here. They have, with the R2, could be an electron withdrawing group like chlorine. Uh, I'm sorry, the R1 is an electron withdrawing group like chlorine or fluoride. The R2, there has three different types of side chains, and what we call aliphatic, piperidine, or piperazine. And the side chains can affect the potency of these compounds. There are many of these that have been synthesized. They're still approved and still in use. In addition, you can get a whole other class by changing the nitrogen to a carbon where the R2 side chain comes off. And these are called thioxanthines. And there are many of those that have been synthesized and approved. As a general, in general, the thioxanthines are even weaker in potency than the phenothiazines. So I think this structure reminds you of something we just covered the other day. It's a three-ring structure. So if you look on the next slide, you can see here the comparison between imipramine, a prototypical tricyclic antidepressant on the left, and promazine, which is a phenothiazine, on the right. And the only difference between these is in the middle ring, where the imipramine has an ethylene linkage, CH2CH2. That's replaced with a single sulfur in the phenothiazine. So you might then imagine that many of the effects of the phenothiazines are going to be similar to the effects of the tricyclic antidepressants. And you can see, except there are some differences. The differences come about in part because the 3D structure of these are somewhat different. Because of that ethylene linkage, the tricyclics can bend around that CH2CH2 and sort of fold, whereas the phenothiazines with the sulfur group are much more planar and rigid. So they mimic some of the side effects of the tricyclics, but they gain some other properties and lose certain other properties. And the next slide shows what that is. So what happens is we see that the phenothiazines share a lot of the same receptor blocking properties as the tricyclics, such as the alpha-1 adrenergic antagonism, histamine H1 antagonism, muscarinic acetylcholine antagonism, but they also take on the property of dopamine receptor antagonism, which was not a property shared by the tricyclic antidepressants, but they lose the ability to, for the most part, to block the amine reuptake pumps that the tricyclics presumably were working through therapeutically. So just to reiterate, refresh your memory again of the autonomic side effects that occur or had occurred with the tricyclics, the same ones occur with all of the phenothiazines. And that is what happens is we see, again, that if you block alpha receptors, you get orthostatic hypotension and erectile dysfunction. If you block histamine H1 receptors, you get sedation and weight gain. And if you block muscarinic acetylcholine receptors, you get all the sequelae of atropine-like effects, such as blurred vision, dry mouth, constipation, urinary retention, and mental confusion. Now, what in terms of what the therapeutic target is for the phenothiazines, in terms of their ability to treat schizophrenia, what one can show, it's shown on the next slide, that the many phenothiazine derivatives that have been synthesized and approved vary greatly in their potency. By that potency, we mean it's not necessarily efficacy, but the amount of the drug needed to get an effect. And you can plot the potency, which I guess is we're calling here clinical efficacy, with the ability to block either D1 or D2 receptors. Those were the only receptors known back starting from around 1970. We could distinguish a dopamine D1 from D2 receptors pharmacologically. There actually are 5 dopamine receptors now that have been cloned. That's all there seems to be. D3 and D4 are D2-like, and D5 is D1-like in terms of sequence similarity and binding properties. But what we see on the next slide is that these phenothiazines all show a straight line correlation with ability to block the dopamine D2 receptor, but not with the dopamine D1 receptor. So it appears that the dopamine D2 receptor is believed to be the therapeutic target for these drugs. Okay, so what dopamine pathway, what are the major dopaminergic pathways in the brain? And I show this in my version of it, a simplified version I show on the next slide. And there are basically 4 major pathways: the mesolimbic, mesocortical, nigrostriatal, and tuberofundibular. So the mesolimbic goes from the ventral tegmental to the limbic area of the cortex and seems to control things like emotion and memory. The mesocortical also goes from the ventral tegmental, but in this case to the prefrontal cortex, and that's necessary for executive functioning like motivation and planning. The nigrostriatal goes from the substantia nigra to the putamen caudate nucleus, and that's responsible for movement. And the tuberofundibular goes from the arcuate nucleus to the pituitary stalk, where it acts to tonically inhibit prolactin release. Okay, so when we talk about schizophrenia, there are what we call the characteristics are, or symptoms are, there are what's called positive and negative symptoms superimposed on each other in patients with schizophrenia. And I list on the next slide some examples of these. So what we mean by positive symptoms are hallucinations, delusions, manic state, even hearing voices, for example. These are referred to as the positive symptoms. But there is a lot of what types of negative symptoms. I've listed them all, starting with A, which means without, from the Greek. So alogia means without speech or poverty of speech. There's affective blunting. There's avolition, meaning essentially the avolition essentially means like a severe lack of initiative to accomplish any purposeful tasks. There's apathy, and anhedonia is without or lack of pleasure. So a lot of the negative symptoms actually kind of mimic the symptoms in many ways of a major depressive disorder. So sometimes it's not that easy to distinguish when you're trying to diagnose patients. But the positive symptoms would be a clue, more or less, for somebody that might have schizophrenia. So based on the fact that all of these drugs showed a straight line correlation with inhibiting the dopamine D2 receptor, people put out early on what's called the dopamine hypothesis of schizophrenia, knowing that these types of symptoms exist as well. And that's shown on the next slide. What you see here is that this theory holds that excessive dopaminergic activity in the limbic area results in the positive symptoms, while reduced dopaminergic activity in the frontal cortex contributes to the negative symptoms. And then consistent with this is the observation that the phenothiazines are capable of reducing the positive symptoms but have no ability to improve the negative symptoms. Okay, so the other thing is with in addition to the side effects that of the autonomic side effects similar to tricyclic antidepressants, in as much as this inhibits these phenothiazines inhibit D2 receptors, there's a whole lot of other side effects that arise from inhibition of those dopaminergic pathways. So the next slide shows what some of those are. Typically you have extrapyramidal symptoms, or EPS, which is a term used for all of these sort of movement disorders associated with the use of the phenothiazines. You get dystonia, like acute contractions of the face and neck, akathisia, which we mentioned before, that sometimes occurs when you initiate with an SSRI, and that's this kind of inner restlessness. The patient can't even sit still. You also get Parkinson-like motor abnormalities. You get rigidity, akinesia, means lack of movement, and tremor at rest. A particular nasty effect of phenothiazines is tardive dyskinesia, which, as the term indicates, it's a late occurring dyskinesia that occurs after you've been on these for quite some time, which you develop these involuntary movements of the face, mouth, and tongue. And as many as 20% of patients being treated with this develop tardive dyskinesia. And the reason it's sort of nasty is that even when you withdraw from the drug, only about half of them recover and from that tardive dyskinesia. The others still have it. And then there's something we call neuroleptic malignant syndrome, which is a true medical emergency, which sometimes occurs again when you first initiate treatment with phenothiazines. After just a few days, people might develop this, and the percentage is somewhat small. 0.5% of patients treated with phenothiazines will develop neuroleptic malignant syndrome, which has to be dealt with and treated immediately, otherwise it leads to death. We'll talk about that in the conference, as one of those case conferences. And then they also, because of the fact that the prolactin is tonically inhibited by dopamine, if you inhibit the dopaminergic pathway and the tuberofundibular pathway, you get these endocrine effects due to increased prolactin release. It produces galactorrhea and amenorrhea in women, Galactorrhea is spontaneous milk production. Amenorrhea is loss of periods, and you get gynecomastia, or breast development and impotence in men. And this is very typically happens with all of the phenothiazines, all of those drugs that were used for schizophrenia for many years. One of the things that the companies did was to get away from at least the autonomic side effects, was to screen for more and more selective, specific dopaminergic D2 receptor antagonists, and many were made, and they developed more selective and more potent D2 antagonists. On the next slide, I mentioned one of these that was developed, that was and it still is in quite high use. It's the butyrophenone haloperidol, or Haldol is the trade name. So in as much as this is much more of a pure D2 receptor antagonist, it gets away from the autonomic side effects, but again, as you might imagine, by being more potent on inhibiting the dopamine D2 receptor and the dopaminergic pathways, you actually get more of the side effects that result from blocking dopaminergic pathways. So you can see on the next slide that I mentioned, you get higher incidences of all the EPS movement disorders, and more incidence of tardive dyskinesia. And again, haloperidol only reduces positive symptoms, no improvement at all in negative symptoms, and if anything, it actually worsens the negative symptoms. So these were the drugs that were available for 40 years, from 1950 to 1990. It's all we had. And then in 1990, one other agent was produced that seemed somewhat different. That's on the next slide. That's clozapine. It's highly in use today as well. And that became available in 1990 and was released as considered the first atypical antipsychotic. It's called atypical. Why? Because it produces much less EPS movement side effects than all of the earlier drugs, and it seemed to have some improvement of the negative symptoms as well as reducing the positive symptoms, which none of the other drugs ever did. It also proved effective in clinical trials for treating prior treatment-resistant patients. One of the problems, though, with clozapine is that in 1% of the patients would develop agranulocytosis. So that limited some of its early use, but it's still been brought back into pretty regular use. You just have to monitor by CBC for agranulocytosis. So looking at clozapine to see what are all of its various biochemical mechanisms that might make it somewhat different from the other drugs, that it can produce these effects where the others couldn't. What we found, and you see on the next slide, is that it had a reasonably high affinity for the D2 receptor, Ki of 190 nanomolar, but it even had a much higher affinity to antagonize the 5-HT2A receptor with an affinity of 3 nanomolar. You might recall from Core A that affinity is inversely proportional to Kd or Ki. So the higher the Kd or the Ki, the weaker the affinity, the lower the number, the greater the affinity for binding. So this was interesting in that it showed not only could it block dopamine D2 receptors with reasonably high affinity, but it blocks the 5-HT2A receptor with even higher affinity. And that seemed to be a clue that might have something to do with the properties of it being having a more beneficial profile than the other earlier phenothiazines. Unfortunately, it also the clozapine has a high degree of autonomic side effects because, like the phenothiazines, it binds to all these other receptors, alpha, 1, histamine, muscarinic receptors, and even nicotinic receptors and other serotonin receptors. So, so the question came about is, was this blockage of the 5-HT2A receptor somehow important in the profile of this drug? So a clinical experiment was done, shown on the next slide, that indicated that it probably is. Because what you can do is you can give a pure D2 antagonist like haloperidol, and along with it give a 5-HT2 antagonist like ritanserin, and see what happens with the symptoms that the patients exhibit. And in fact, you got less incidence of EPS, movement disorders, and some improvement of the negative symptom profile. So as a result, then the companies decided to start screening for agents that could inhibit both dopamine D2 receptors and the 5-HT2A serotonergic receptors. And they screened for those and came up with a drug in 1996 called risperidone, or risperidol, I think is the trade name. That was released then, and 9 more have followed since then. So we now have a whole group of what they call what's referred to as the new atypical antipsychotics, and that's shown on the next slide. And this is what we have and when they were produced. So some things you should know about this. First of all, 2 of these, the risperidone, which I just mentioned, and paliperidone down here, are very similar because the paliperidone is nothing more than an active metabolite of risperidone that was then marketed separately. So they do almost identical things, which I'll allude to. I think I already did that. They still affect the tuberofundibular pathway, these 2 drugs, in that they increase prolactin and result in those endocrine side effects. None of the other atypicals do. Okay, they're free of any effects on tuberofundibular, but the risperidone and the paliperidone are not, and they still cause the endocrine side effects. Also, the last 3 on this list, four things on this list, not those 3. The aripiprazole, and then the 2 at the bottom, brexpiprazole and cariprazine. Okay, the aripiprazole, the brexpiprazole, and cariprazine differ from the others in that they are not antagonists of the D2 receptor. Those 3 are actually partial agonists of the D2 receptor, although they also still are potent antagonists of the 5-HT2A receptor. So, as we'll talk about, they have a little bit better favorable properties, and they're considered or called dopamine stabilizers, which we'll get to at the end of this talk. Okay, so what all these agents were screened for as inhibitors of 5-HT2A and dopamine D2, and we call them sometimes serotonergic dopaminergic antagonists. And as I mentioned, they're all antagonists of the 5-HT2A receptor, and all but those 3 I mentioned, aripiprazole, brexpiprazole, and that other one, are partial agonists of D2 receptors. The rest are all antagonists of the D2 receptors. So the question came up then: well, if most of these, in any event, are antagonizing D2 receptors, why do they produce less EPS, and why are some of them somewhat capable of improving negative symptoms a little bit? And how do they do that? So there were two hypotheses put forth for this. The first one was put forth by Herbert Meltzer. He's at Northwestern Medical School. He wrote most of the chapters on this in Katzen and Goodman and Gilman, the chapters on antipsychotics. And this is his hypothesis. He points out that the was put forth by Phil Seaman. He's currently an 85-year-old fellow who's working at the University of Toronto. And Seaman was the fellow who actually discovered the dopamine receptors and first characterized them back in the early 1970s. And his hypothesis says that the fast dissociation from D2 receptors is what makes the atypical antipsychotics atypical. Effectively, what that means is he's just saying that they have a different affinity for the receptor than dopamine, a lower affinity. The atypicals have a lower affinity for the receptor than dopamine itself, whereas the earlier drugs, the phenothiazines and haloperidol, have a much greater affinity for the receptor than dopamine. So therefore, he's saying when you get a surge of release of dopamine, it can knock the atypical antipsychotic off the receptor because they have weaker affinity for it, but it'll never knock off haloperidol or the phenothiazines because those affinities are so strong. An example of that I've tried to put in diagrammatic form is here. And you can see what his idea is, that when you have a surge of release of dopamine to activating a particular dopaminergic pathway, if you have haloperidol sitting on the dopamine D2 receptor, the dopamine is not going to move it off. The haloperidol has a much greater affinity than dopamine. But if you have something like clozapine that has a weaker affinity for the receptor, as you increase dopamine, it'll knock the clozapine off, and so that pathway won't be fully inhibited, like it would with an earlier antipsychotic drug. And you can see the KDs on the right-hand side. And dopamine has a KD of about 1 nanomole for the receptor. All the earlier drugs you can see, have a much higher affinity. They have a lower KD, which means the affinity is higher. And all the atypical drugs have a higher KD, which means their affinity is lower. So what do we know about these new atypicals now that they've been in use for, I guess, almost 20 years now, or more, actually? Okay, so this effect of agranulocytosis is something specific just for clozapine. None of the other atypicals show that, so it's something specific to clozapine. And unfortunately, all of the atypical antipsychotics are not devoid of autonomic side effects. They all interact with varying degrees, and I'm not going to go into which one is which, but they all have ability to interact with these other receptor systems, alpha, histamine, and muscarinic receptors, and thus they all produce some degrees of autonomic effects. Most troubling is that after more and more people were prescribed this for longer periods of time, what we began to see is that in many patients treated with these atypical antipsychotics experience considerable weight gain and development of metabolic syndrome. Metabolic syndrome is characterized by hyperlipidemia, hyperglycemia, hypertension, hypertriglycerides, increase in triglycerides, and this, when unchecked, leads to type 2 diabetes. And this is what was beginning to happen with many patients taking the atypical antipsychotics. And it's a bit of a problem. So these patients should really be screened for these effects, for whether or not they're developing metabolic syndrome when being treated with these. Now, within the class of all the atypicals, there are some that produce somewhat less weight gain than others. In particular, ziprasidone is one that does. And in addition to ziprasidone, the three that I mentioned that are partial agonists of the D2 receptor and not not antagonists, the aripiprazole, the brexpiprazole, and the cariprazine also produce less weight gain. And then, as we mentioned, none of these affect or increase prolactin release like all the older drugs did, except for risperidone and paliperidone. They still do, and you have to keep that in mind. So, other things we know about the atypical antipsychotics is that, as shown here, they seem to, well, actually, I have to walk back on this a little. I say it's really only clozapine that's been shown in clinical trials directly to have superior efficacy in treatment refractory populations. I don't think the trials have been done yet with the other atypicals, so that may not be the case for them. They again, it's clozapine seems to show some efficacy for the negative symptoms. The presumption is the other atypicals will as well. The clinical trials have yet to really show that. But they all seem to have reduced amounts of EPS at clinically effective doses. I wouldn't say that they're absent, but less so than the earlier drugs. Also, clearly there's less incidence of tardive dyskinesia. And again, they all are free of the endocrine effects from increased prolactin, with the exception of risperidone and its active metabolite paliperidone. So, what about those three newer ones that I was talking about? The aripiprazole, brexpiprazole, and cariprazine. So, the companies try to refer to these as dopamine system stabilizers. What do we mean by that? If you remember back to Core A when we talked about receptor theory, if you have a partial agonist will, no matter how high you go, it will never reach full efficacy. It'll only partially activate a pathway. In addition, in the presence of high concentrations of the endogenous neurotransmitter that it's whose receptor it's acting on, it would actually act as an antagonist because it will displace the dopamine itself, for example, at the high concentrations, will displace it from the receptor. And it doesn't have a full efficacy, so it's almost like going to antagonize the response you would have gotten from the dopamine itself. So, as I say here, they act as agonists when local concentrations of dopamine are low, and as antagonists when the local concentrations of dopamine are high. So diagrammatically, I try to show this here. If you look on this slide, I don't know how this is going to come out with this narration, but maybe it'll work. So if you add dopamine, and you get 100% of a response. If you add haloperidol, which is an antagonist, you get no response. There's no response to an antagonist by itself. If you add something like aripiprazole, which is a partial agonist of the D2 receptor, you get a response, but no matter how high you go in the aripiprazole, you're only getting a partial response. It'll never match that of dopamine. Now, in terms of what happens when you try to inhibit the system, if you add haloperidol, which is a potent D2 receptor antagonist, you can completely block the effects of dopamine. But if you add something like aripiprazole, which is a partial agonist, it acts as an antagonist here and reduces your response, but not completely. It only reduces it to a certain level where it plateaus off. And what is that level? That is the level at which it would normally produce a partial agonist activity. So therefore, the companies are saying these drugs are dopamine stabilizers in that they keep the dopamine levels where they might be or where they should be, better than the other kind of drugs. So in summary, what we have for antipsychotics is the first generation are the phenothiazines, the three-ring structures with the sulfur group. They act via D2 receptor antagonism. They produce enormous amounts of autonomic side effects and extrapyramidal symptom movement disorders. They were good at reducing the positive symptoms, but had no ability to improve negative symptoms. The haloperidol, which is a more second generation, was a more potent selective D2 antagonist, had fewer autonomic side effects, but it created more EPS, and it also had it could definitely reduce positive symptoms, but it actually worsened the negative symptoms. And then we came along with the atypicals like clozapine that inhibit D2 and 5-HT2 receptors. They have less EPS, but then they were found to produce diabetes as a consequence of inducing metabolic syndrome. But they definitely reduced positive symptoms, and to some extent, at least with clozapine itself, they could improve negative symptoms. The presumption is the others will show that to some extent. And then finally, we have these dopamine stabilizers like aripiprazole that are partial D2 agonists, and they seem to produce less weight gain than the other atypical antipsychotics, and also show reduced EPS movement symptoms. Okay, that's it. Thank you.